I would also like to welcome our former colleague, Mr. Ayman Ewies, who is consultant gynecologist and again at Sandwell and Westbury Birmingham Hospital in West Midlands in the UK. He's an honorary senior lecturer at the University of Birmingham. He's the deputy academic lead for year 3 and lead of professional development activities module. He has the cultural resources advisor, which includes the core e-learning, the continuous professional development e-portfolio, the training e-portfolio, the website resources for the Royal College of Obstetricians and Gynecologists in the UK. He's also the associate editor of the Journal of Obstetrics and Gynecology. And tonight, he is going to talk to us about office hysteroscopy, from general anesthesia hysteroscopy to see and treat. Now, it is my privilege to introduce Mr. Ayman Ewies, as I introduced him previously, and he's going to talk to us about office hysteroscopy and the from general anesthesia to see and treat. Mr. Ewies.
Thank you very much. Can you see my presentation? I shared it.
Yes, we can.
Thank you. Good evening, everyone. My presentation is about office hysteroscopy service, challenges and tips for success. First, I would like to thank Professor Sallam and his honorable committee and colleagues for this kind invitation. And also, I would like to greet my former colleagues, Abdelmajid Sarhan and Gasser al-Bishri, who are in your committee as well.
Yes.
Diagnostic hysteroscopy is the gold standard for assessing the uterine cavity. It replaced the blind and inaccurate technique, D&C, which became outmoded in the UK practice since 1980s. Routine diagnostic hysteroscopy under general anesthetic is an anachronism. We only offer it if office hysteroscopy fails or in case of patient preference. Recently, the hospital episode statistics in England during the COVID pandemic showed 70% reduction in elective theater procedures and 31% reduction in office procedures, i.e. during the pandemic, cancellation of the procedure hit more the procedure in theater, not office procedures. Therefore, to improve service efficiency, reduce backlog and waiting lists, etc., we must move procedures out of theater. The scope of contemporary office hysteroscopy include diagnostic procedures. We take directed biopsies in office, cavity assessment prior to ablation, assessing submucous fibroid to see which one to be done under general anesthetic and which one in office. Also therapeutic, we do hysteroscopic polybectomies, myomectomies, ablation, retrieval of coils, and also we treat septum. Hysteroscopic sterilization is not performed in the UK anymore. I would like to share with you my experience and our milestones. So we have done our first hysteroscopy unit, procedure in our unit in 2001. It took 10 years to develop into operative, and we have done our first NovaSure in 2011, then first VersaPoint polybectomy in 2011. We replaced the VersaPoint with MyoSure in 2017, and last year we introduced Omniscope to be able to proceed with see and treat, as I will explain to you. How to set up a service? I will categorize it into why, what, who, how. So as Martin said, the drivers are the patient choice, patient safety, shorter journey in the system, cost effectiveness. The barriers usually lack of resources or lack of expertise, old habits, protecting own practice. Most women like it. No general anesthetic, increased number of obese women and women with comorbidities in societies. Women can go back straight normal activities. No fasting, no hypoglycemia, no dehydration, no vasovagal attacks. We presented our patient satisfaction data in some congresses recently, and we handed 10 itemized questionnaires prospectively to 100 women attended our unit for diagnostic and operative procedures. And we used visual analog scale as an objective method of assessment. Actually, 93 women stated they would have the procedure again if clinically indicated in office. 97 would recommend it to friends. And all women said the staff were welcoming, supportive, the procedure was well explained, the dignity was maintained. Why we do office hysteroscopy? NICE, the body that produces clinical practice guidelines in the UK, recommend that office hysteroscopy should be offered to women with menstrual abnormalities. Vaginoscopy should be the technique of choice. And you should set up the service such that you can progress to see and treat if required. Also recently, National Day Surgery Delivery Pack guidelines in September 2020 recommended that these procedures should be moved from theater. And as Martin said, in the UK, the practice has moved away to move this procedure in theater, but after the COVID-19, it became mandatory in centers which they don't. Cystoscopy, hysteroscopy, evacuation of retained products of conception, and endometrial ablation. How we do it? We have a unit with right atmosphere, confidence, competence, smoothness, relaxed, friendly atmosphere. We ask patient to bring with them a friend. We offer them tea, coffee. We don't use the scrubs or masks to make it as friendly as possible. One of the important things, you have to have your clear, strict referral criteria because the procedure is easier to be done in office. Sometimes the service get overused or abused or unnecessary used, where the procedure are offered to women who don't clinically need it. So we have a strict referral criteria. So we have a venue which is fit for purpose, health and safety compatible, reception area, waiting area, consultation rooms, treatment suite with integral changing cubicle, and recovery suites with recliners and some beds. This is our unit, the receptionist on the right-hand side. We have 6 rooms, 1 for a scan, 3 consultation room, 2 procedures room where we do NovaSure, MyoSure, 1-stop PMB, and colposcopy, and we have a dedicated waiting area. You can see on the right-hand side the doctor's desk, sink to wash your hand, cubicle for patient to get it changed, the couch, and the equipment. This is our recovery, and you can see our recovery is slightly different from Martin's unit, where we have recliners and also we have beds. Some occasionally patient feel faint or something. It doesn't happen often. Actually, the patient use the recovery area in our unit from 0 minutes up to 45 minutes or so. So some patients actually leave the room after NovaSure even, go home straight away. As regards patient, you have to select the right patient, the motivated one, not extremely nervous or patient prone to panic attack, well informed. They have read your patient information leaflet, already consented, had something to eat. When I do the procedure, I have a staff nurse for the equipment and 2 assistant nurses. One, the patient advocate or the vocal local, as we call it in the UK, and one to admit.
Number 15, 6-3.
What? The equipment, we have modern scopes, stacks, operative equipment, and also resuscitation facilities and emergency box are important. Severe vasovagal attacks are rare, but do occur. Complications are rare, but do occur. So be prepared. To be honest, since I established and started this unit 11 years ago, we never had any major complication. Also, if you establish a unit, you have to have your own policies and guidelines. We have our own referral pathways, our analgesia protocol, procedures protocol, post-operative care equality policy, patient information leaflets for every single procedure. And also our trust has moved from handwritten records. We have electronic records. Our analgesia protocol is slightly different from Shrewsbury. So to be honest, my tips is that I am honest. I tell the patient they will have some pain. So when the patient is mentally ready, they will have some pain. They will cope better. So the pain is short-lived anyway, and I warn patients about noises and cold saline. Also, distraction is the key. The role of the vocal local is crucial, and I let the patient watch the screen. I empower patient because before they go into the couch, I empower them to tell me stop if they want to have few seconds of break. So when the patient feel they are in control, they cope better. Vaginoscopy for diagnostic hysteroscopy. I use the small scopes and I use low pressure. Patient cope well if they have read the patient information leaflet. I wish I could warm the saline to 36 degrees, but the nurses wouldn't let me. From my experience, anxiety is the key, not the pain. I have not come across patient who didn't like the procedure because of pain. The anxious patient who are prone to panic attack, who have phobia of a doctor or a nurse or a hospital, are the difficult one to bring into office. Our analgesia protocol, again, slightly different. Our patient information leaflet tells the patient to take ibuprofen and paracetamol 1 hour before the procedure. During the procedure, we give patient Entonox, which is 50-50 mixture of nitrous oxide and air, gas and air. We avoid opiate to prevent the sickness and help a quick discharge. I personally avoid local anesthetic except for NovaSure operation. I give local anesthetic only if I dilate. If I don't dilate, I don't give local anesthetic. If the patient needs dilatation, maybe to 5 or 6 millimeter, I rely only on gas and air. I don't give also local anesthetic. In our unit, we don't use the focal local or fundal block. We rely on gas and air and the local anesthetic, but not fundal block. Our local anesthetic protocol, I use 4-quadrant intra-cervical block using lidocaine and epinephrine. The trick is when you do intra-cervical block is, look at the photo on the left side here. You insert the needle high in the cervix, the full length of the needle, 3 centimeter, intra-cervical, not like the photo on the right side when you give injection superficial. The reason is the lower 2/3 of the uterus are supplied by the inferior hypogastric plexus. So you have to inject the needle high up to 3 centimeter. For the upper third, which is supplied by the superior hypogastric plexus, we rely on gas and air. The procedure that we do in our unit in office is the NovaSure Ablation, and Martin kindly covered this. We also do MyoSure. MyoSure is the morcellation technique to remove polyps and fibroids in office. It comes in 3 different devices. One, light, MyoSure Light to remove small polyps, and MyoSure Reach to remove large polyps and moderate fibroid, and MyoSure Excel for large fibroid. There is MyoSure Manual as well, which is not connected to the fluid system. As you can see, with all types of MyoSure, you need dilatation only to 5.5 millimeter, except with Excel, you dilate to 6. So most of my patients who are multiparous, they actually don't need dilatation. Hence, I am conservative in using local anesthetic. It gives patient tachycardia, and in giving the needle itself can cause pain. So I'm just try to minimize the pain. However, I'm not saying I don't give local anesthetic, but if I can work without it, will be better for patients. The Omniscope, which we introduced last year, allows us to proceed with see and treat. the MyoSure device fit into the Omniscope, i.e. we do all our diagnostic procedures with Omniscope. So if you are in the uterus and you find a polyp or fibroid, you don't have to take the scope out and insert another scope in to treat. Through the Omniscope, you can put the MyoSure device and to proceed with treatment. I will show you a short video about a MyoSure procedure for submucous fibroid. Great note. For a patient with postmenopausal bleeding, you can see the endometrium is thin and normal. And this patient needed gas and air and also needed local anesthetic for cervical dilatation. You can see that MyoSure is morcellation. It doesn't have energy with it, i.e. if there is bleeding, there is no way to stop it. Therefore, you have to select your cases for the non-vascular fibroid. Assuming if this fibroid was very vascular, for example, probably either I would have given her GnRH analog to reduce the vascularity in advance and to bring her back, or I would have booked her under general anesthetic if the fibroid is large. I would say this procedure in real life has taken 10 minutes. So I will, to save time, I will move on. The challenges of office hysteroscopy: stenose the cervix in nulliparous women and postmenopausal women, and the previous ablation. However, the main challenges, to be honest, the severe anxiety and the pre-existing pelvic pain. And the challenges for see and treat is the length of the slot, because if you book, will you book in one session 5 patients or 7 patients or 4 patients? If you are relying on diagnostic, it will take less time than see and treat. So this is one of the challenges. Also, patient mental readiness. Of course, it needs high level of expertise. Some of the solutions that we implemented to facilitate see and treat is sending patient information leaflet to patient home address before the appointment, and also telephone appointment with the nurse specialist before the appointment, so the patient get explained that they might have treatment. When you start a new office hysteroscopy unit, I have some tips, like do your first few procedures under general anesthetic, whether it is NovaSure, MyoSure. Even if you started to do hysteroscopy, do your first hysteroscopies under general anesthetic until you are, as we call it, you are sneaky, quick, because the patient wants to be on couch the least possible time and they want to experience the least possible pain. So visit up and running unit. Understand the technology behind your device. It will build up your confidence. Virtual reality simulation training is available. Select your patient well, select your device. Develop policies unique to your unit. Patient information leaflet should be unique to your units. Follow manufacturer instructions to maximize safety. Don't try to invent your own way. Make use of your rep. They are there to help you. To conclude, the philosophy of patient ambulate in and ambulate out in modern gynecology is safe, efficient, convenient, and cost-effective. This reflects in hysteroscopy as office hysteroscopy or ambulatory hysteroscopy. It is now further developed into see and treat or one-stop service. The change in OT practice requires investment in infrastructure, training, the change of mentality of clinicians. The 80% target for office hysteroscopy should be mandatory, should be the norm. And we have to ask ourselves, can we justify subjecting women, especially those with comorbidities, to the risks of general anesthetic for a hysteroscopic procedure? Finally, no ultimate truth regarding how to set up your service. No two centers will function exactly the same way. Our way has evolved and is evolving over time. You don't have to accept all my suggestions, by the way. However, I hope you may adopt some of them, though. Office hysteroscopy, can you do it? I'm sure you can. And thank you very much for your good listening. This is our lovely team in Sandwell and West Birmingham hospitals. Because of the time, I have to skip the 7 minutes video, which shows you the patient journey in our unit. Probably, if there is another opportunity in the future, I might be able to present it. And thank you very much.
Thank you very much, Mr. Ewies, and again, introducing us to something new, at least for me. And we have a couple of questions now, and then we'll leave the rest to the end. Now, we have a question from Professor Ahmed Warda from Alexandria University. He's asking about the follow-up and for how long?
Follow-up for which case? What type of patient?
We didn't specify. Maybe, I guess, for the one of a fibroid that you have removed.
To be honest, we don't have, our follow-up rate is 0 in the variety of the procedure. So the patient with, say, NovaSure, we tell them, see how it goes in 6 months' time. If in 6 months you are not satisfied with the procedure, probably the GP can refer them back. Our data, the data from our unit about NovaSure, that 91% of women didn't require hysterectomy. 9% of women required hysterectomy after NovaSure. And the median period of duration from the initial NovaSure to hysterectomy was 1.1 years. This data is like in press at the moment, has not been published yet. So about the patient will know whether they want another procedure about 1 year after the NovaSure, but we don't follow them up, the GP follow them up. After removal of the fibroid, follow-up is not required. We write to the patient with the histology report to their home address.
Yeah, thank you very much.